Okay, we can always pause anytime along the line.
There's going to be learning and starving.
Learning and starving. I'm a fat guy. There's no chance of starving during that. Okay, so let's get started. Anybody that doesn't know me, I'm Matt Lardy. I worked at Trinity for about 2 years now. I came in a kind of an unusual contract position, basically about ICD-10 codes. Come on in. Basically about ICD-10 codes and a process within the state of California. So I am not a classical coder as are many of you folks. So today's topic is kind of a 30,000-foot overview of ICD-10 codes and what they are and kind of how they relate to healthcare in general. We do a lot of healthcare work here at Trinity, but this is a different aspect of healthcare that we haven't done a lot of. We do the reimbursement side, we do technology, but we're going to talk today about a different set of codes. So lots of you can understand what this means, right? HTML, JavaScript, ad nauseum. This is the type of coding that Trinity does, and lots of our folks do. This is my coding world. When you do this, it transforms and tells the computer to do something, and it shows you an image. This kind of coding takes a circumstance, an event, a happening, translates from longhand what the physician writes, and allows us to compress it into very short, succinct codes. Now, all of these codes have a meaning. They stand for something. The codes on this side have dollar values. The codes on this side over here have no dollar values, but they're diagnosis codes. When you match these two codes, types of codes together, that's how you get reimbursement. If you don't match them together correctly, you don't get reimbursed, or you get decreased and diminished reimbursement. And we'll talk about some more specifics as we go, but they're very, very different types of coding. My coding, other types of technology coding is to make things happen. I come behind and translate what a physician has done into codes. So it can go into a computer with the codes that everybody else works on and then spit out money on the other end. So lots of people think that coding is something that's relatively new in terms of medical coding. The very first coding work was done in the London Bills of Mortality in 1662. So my codes have been around a whole lot longer than everybody else's. This was really the initial beginning for all codes, was about describing how people died. It wasn't about health. It was all about mortality and morbidity, why people got sick and how people died. People died all over the globe, but how could we describe how they passed away? Well, this first work was in London, and it was all about live-born children who died before they reached the age of 6 years old. That's what this initial sets of code were used to describe. And if you look at some of these conditions, thrush, convulsions, rickets, teeth, worms, all of these strange things that nowadays we don't have for the most part in terms of conditions. But the initial work is all about mortality, what caused us to die. So that's how codes began. About 1940, Surgeon General of the United States Public Health Service and the director of the Bureau of the Census, see the tie as we go back to death, life and death. We needed codes to report where people were born, how people lived, how people died. It all ties into population and management. They created some of the first manuals of codes that were related to the death of patients. When we look at the old ICD codes, we'll see some strange throwbacks. Fall from horse-drawn carriage. Fall or injury caused by a cotton gin. Now, we don't see many cotton gin injuries nowadays, but if you go back to the old set of codes, and some of them are still valid, they have those kinds of descriptors. Those were the very beginning of the code set, how people died, what caused their death. Coincidentally, the very first chapter in the modern codes is all about communicable disease. What killed us the most in the 1600s was communicable disease and accidents. So that was the biggest and the first chapter in all of modern coding is all about communicable diseases. We had to describe how people died. If you didn't have a communicable disease, you died of old age. Till we got better with pathology and understanding the life process. But that's how the code structure actually began, way back in 1662, and has slowly evolved since. So we're going to zoom forward from those initial sets, and we're going to talk about 7, 8, 9, and 10. The 7th revision of the ICD, International Classification of Diseases, was held in Paris, sponsored by the World Health Organization, 1955. That was the real modernization and looking at using these diagnoses codes for more about population health reporting. So, first in 1955, first American use. Then the 8th revision, and notice that it's 55 to 65. We revise these typically about every 10 years. The World Health Organization called all the medical societies from around the world. They all get together and they revise these codes about usually, and these days, every 10 years. So 1965, everybody got together again in Geneva, restructured the code set, and that was ICD-8. Finally, ICD-9 met in 1975, another 10-year jump, the 9th revision, ICD-9. That's what we're currently using today. Now notice something jumped because we went all the way from 75 to 2015, at least in America. This ICD set is an international code set. It's published in multiple languages by multiple countries. One of the problems in medicine has always been how doctors communicate with each other about diseases and illnesses. As the world got to be a much smaller place and people traveled from country to country, the need for physicians and medical societies to speak across borders, across oceans, got much more important. And we knew that we had to have a common set of language. Well, language is not common, but mathematics and codes are. So the codes evolved from terminology to terminology linked with alphanumeric values. So, enormous growth of this code set since 1975. We now have this great way of saying this, spreading this information. What are we going to do with it? What can we do with it? How do we move it forward? We're still using 9. And then ICD-10 came out in 1993. So we're saying, why are we so far behind? We did this back in 75, and that was ICD-9, and 1993, it came out as ICD-10. Yes, it did. We'll talk about why we haven't jumped to it in just a minute, but all the different places in the world, this is just a few of the modern, quote, modern countries. Canada, China adopted in 2002, Czech Republic, France, Germany. Notice ICD-10 GM, German modification. We have ICD-10 CM or ICD-9 CM, a clinical modification. We'll talk about those a little bit as we go. South Africa, Sweden, Thailand, the UK, the United States. We were going to adopt this in 2013. We said, yep, this is what we're going to do 2013. No, no, we can't do that. We can't do this. There's a reason we can't do this. Why? Well, because it's going to cost too much money. And every year, we keep knocking it back and saying it's going to be another year, another year, another year. The new codes come out every year or the revisions come out on October the 1st. So we started out with 2012 and 2013, then 14. And then this year is going to be it. We've gotten closer to the actual go live date than we've ever gone before. Way closer. So, why change? All right, why do we change? Well, medicine has changed a lot since 1975. How common were heart transplants, lung transplants, kidney transplants? Oh, they weren't. They were very uncommon things that were occurring. Nowadays, they're everyday occurrences. Cardiac bypasses, hip replacements, all of these things have evolved in medicine. Medicine kept changing. The codes didn't change very much over the years. Now, content now, no longer clinically accurate or adequate even to describe what we do. Our doctors do things that they could never have done before. We have the ability to look inside the human body better now than we've ever had before. We know why things happen. Back in the 1600s, it was demonic possession or whatever it was that caused somebody to die. Oh, they had the consumption. Anybody ever heard that phrase, consumption? It's an old-fashioned word for tuberculosis. Anybody ever heard of lumbago? Oh, my lumbago's acting up. Lumbago. It's a great word. It sounds like something you should be enjoying with a glass of lemonade down in the South on the front porch. Lumbago in the South is still a valid diagnosis. People still understand it. All it means is low back pain. All right? What they say in Georgia is not the same thing that they say in California, but the code is. So the codes stay the same, the terminology changes. We actually moved to ICD-10 codes for reporting mortality a couple of years ago. That was just the cause of death piece in the ICD-10 code sets. So the pathology world and the census world accepted it, but the rest of the medical world didn't. Kind of funny, you would think that if we could describe the cause of somebody's death, we could use that within the rest of healthcare. And that would have been a great thing to do, but we couldn't. There's kind of a few reasons. One of the problems is we see the rest of the world is using ICD-10, the rest of the modern world. We have the leading medical societies in the world today, and yet we're 30 years behind them in terms of the code set usage. Shouldn't be, but it is. That's where we're at today. One of those problems translates into the fact that our data that we share with the world is now coded differently with what the rest of the world uses. Our code structure doesn't match theirs. It doesn't say the same thing. It doesn't neatly do what's called crosswalking. You'll hear a lot about ICD-10 crosswalks nowadays. Been building them for years, and that is how the 9 and the 10 codes relate to each other. They don't relate well. There's some big differences, but right now we can't, as a company, as a country, communicate with the rest of the world about illnesses and cause of death very effectively without this crosswalk that goes in between. So here's one reason why we need to change. We can't communicate with the rest of the world. It's important. The ICD-10 CM and PCS code sets really change the availability and the amount of data that we have. One, tracking public health In terms of complications, we couldn't track complications well before in ICD-9. We can now. Anatomical location. Old code sets just described a bone broken. They didn't say right or left, upper, middle, lower. They said it's broken. What else do you need to know? Pay the bill. Improved data for epidemiological studies, which is the spread of diseases like the big Ebola crisis. Did the ICD-9 versus ICD-10 code structure hurt that? Yeah, it did. Be able to track those types of diseases and illness. We can now measure outcomes. Anybody ever heard of the Affordable Care Act? We're working with that right now. Well, measuring outcomes. Old code set 9 does not measure outcomes well, does not allow us to measure outcome. It's really, ICD-9 is really all about reimbursement. 10 allows us to measure outcomes better, make better clinical decisions. Because medicine has changed, now the codes and the definitions have changed. We have the ability to expand that. Fraud and abuse is something we're all concerned with, especially with the Affordable Care Act. More accurate codes means a physician can describe what's going on more accurately. And instead of using these blanket wide codes, we can identify specific codes and we can keep people from just using a throwaway junk code to try to scam the system. And ICD-10 is much better for payment systems. Right now, you've got a group of codes and these codes pay this amount. Diagnosis or not, they're only going to pay this amount. If we can move forward in the future with a broader, more granular diagnosis set, you know, if we look at this whiteboard, it's pretty smooth. We don't see grains in it. But if we look at the table, we see all these grains in that wood. That's what ICD-10 is. It's granular. It allows us to dissect it down into the components and figure out exactly what this illness is. If I said that somebody broke their arm on a simple trip, slip, and fall versus someone fell from the roof of a house, which one is going to make you think more about severity? Well, fell from the roof of a house. Same broken arm, but if you can include that data about how they fell and how they were injured, that points to a higher level of acuity that the doctor has to provide. With that code set, you can provide more granularity, more acuity. So, the original language, here's the problem. It's really simple. The original language for these codes were written, for the most part, COBOL. Like 1959 COBOL. Grace Hopper was the inventor of Flowmatic, which was a predecessor to COBOL. She is revered in government IT circles. God rest her soul. Why is it a big problem? It's old. The real problem, here it is. It's just this simple. ICD-9 codes are 5 characters. The structure in every modern reimbursement system is 5 characters long. It can be either 2 alphabetical characters in this first spot or all numeric. That's it. That's what you're limited to. It's not going to go anyplace else. Now, that's the problem, because every system written in COBOL had this 5-digit space hard-coded in, and there was no reasonable way to repair that, to restructure that code. So at the cost of billions, probably trillions of dollars, we replaced it with ICD-10, 7 characters, alpha numeric, and then alpha or numeric characters. Drastically improved the ability to expand the code set, provide more information. But modern systems couldn't use those characters. We had them back when ICD-10 began. The insurance companies said, oh, no, 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 no. You're not going to have us replace our entire system. Medicare says, oh, no, 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 no. We're not going to replace all of Medicare. Because remember, all of Medicare is the biggest payment system in the world. And all Medicaids came from Medicare with their structure and their data and the reporting requirements, all came from Medicare, CMS, and everybody could only use this. So at the cost of trillions of dollars, new systems had to be built. That's why every year we push back. We need another year to build. We need another year to build. We need another few billion to build. That's the real reason why it took so long.
What is the status of state of California adopting this for the Medicare?
Excellent question. The state of California says they're going to be ready to accept ICD-10 codes. That process is the state will accept incoming ICD-10 codes, filter them through a crosswalk that I built back to the existing system logic within the CAMUS system that's all in ICD-9. And we're waiting, as soon as that new HE system comes up, we can take the crosswalk out. It will be native processed to ICD-10 codes. But until that time, everything comes in 10, crosswalks back to 9, and uses system logic. Because it's a costly process and trying to redo system logic and et cetera, et cetera. This is the big reason why 10 is such a big deal.
But if you're not doing native conversion, it really defeats the purpose of this.
It's a lot of the purpose.
Yeah.
A lot of the purpose of what this is all about.
Yeah.
Now, you're still going to get doctors and systems that are going to submit claims with codes. They're still more granular than ever before. They're still going to be collected. They're just going to be not quite as valid. And we'll talk one more spot about that as we get toward the end of today. But every healthcare system uses this. Everyone, including workman's comp, which, by the way, is not mandated to drop or to increase up to ICD-10. ICD-10 for everybody but workman's comp. Workman's comp is not traditionally considered a covered entity under HIPAA. So, in fact, right now, about half the states have not said if they're going to move their workers' comp into ICD-10. Imagine the confusion in a doctor's office that treats both work comp and non-work comp. It's going to have to submit claims in both directions with 9 and 10 simultaneously. Going to have to do that. ICD-9 is going to workman's comp. ICD-10 is going to everybody else. Lots of extra work, confusion for providers, for facilities. This is the biggest problem. So let's talk about some good things. ICD-9 to 10 changed 19 times as many procedure codes. Only about 4,000 in ICD-9, 70,000 in ICD-10. So from 4,000 to 70,000. Huge jump. 5 times as many diagnoses to go from 14,000 to another about 70,000. Huge jump in the number of codes. Alphanumeric instead of only numeric. Chapters have changed. We actually added chapters. We didn't develop new illnesses and injuries. We just, so instead of things being lumped into one giant code that caught everything, we now have much more specific when we talk about the granularity. We have more specificity about what's going on. We'll show you some of those. It's pretty cool what they've done. But let's stop for a minute and remember what the codes actually do. You go to your physician, and the physician needs to know why. What was wrong? What happened? What's wrong? Did I fall down and break my arm? Do I have a cold? Do I have a sore throat? Whatever. What did the physician do? Well, did he or she examine? Did they do a procedure? Did they do both? An examination and a procedure. That's the physician side. For them to get paid, obviously they want to get paid. That's why we call it reimbursement. They've already delivered the service, and then they're going to get reimbursed for the service and expenses that they laid out. That's medicine as a business. That's why it's called reimbursement. Doctor submits a claim. For the most part, thank goodness, we submit them electronically.
What is in that claim?
Patient name, address, date of birth, insurance number, social security, and procedure codes and diagnosis codes. So for the most part, your medical record gets condensed down to what the doctor wrote, transcribed, down into the small set of codes that coders apply to that. So it can be electronically transmitted. And so it can go into a computer system at the end and have the computer, for the most part, adjudicate that claim. The computer has a list of procedures and dollar values and modifiers and diagnoses. And when they come in, they match together through the computer system. And for the most part, that's how they get paid. Before, and I mean in the 80s, physicians still submitted paper-based reports to get paid. Even in the 80s, when I first started coding, 89, not all physicians had to submit diagnosis codes or procedure codes. They would actually submit a typed up report with a text-based description, and somebody had to sit in an office and figure out what it translated to. In 89, in 1989, we were still doing this. That's why this is still so new. So it goes into a computer, the computer processes, in some cases it spits it out for a human review. Intelligence of a computer. So this is what the codes do. There are 3 basic things to remember about these codes. All of these codes that I work with. Most procedures or services have a dollar value, plain and simple. There are differing values depending on where they're done or who's doing them. They have a dollar value. CMS, Center for Medicare and Medicaid Services, they require the documentation of that key nasty phrase, medical necessity. They will reimburse a claim if it is necessary. How do you determine medical necessity from only a procedure code? And the answer is you can't. You need to know why the patient needed it done. That's where the diagnosis code comes in. That's where the diagnosis code supports the reason for doing the procedure. Without that, the procedure just said, give me $150. I want it, give it to me. And that's what happens. So those codes working together comprise how we get reimbursement. ICD-10 codes, or right now ICD-9, they document medical necessity. So an accurate code delivers accurate reimbursement. Solid, steady level. But 3 things. It's got to have a reason for that and link them together. That makes reimbursement. 3 to 5 characters, alpha, 2 to 5, must have at least 3 characters, decimal point after 3. ICD-10, same kind of a physical structure. That's where all the problem is. Right? Just throw this in here as a reference point later on so you can impress people. Now, code structure. This is what an ICD-10 codes look like. P09, it's a 3-character code. Codes are either 3, 4, 5, 6, or 7 digits or characters in length. The only way you can tell if they are valid is if you get in a book or a reference source and look. You can't just provide 091 and submit it, because 091 by itself isn't a valid code. It's a category. It'll get you close into a family of codes, but it's not valid. That's where the computer kicks in and says, this code requires 7 digits. And if it doesn't, it gets kicked out as an invalid code. Longer than 3 have a decimal point. Where we come from in the machine world, the decimal points don't mean anything. We take them out. It's much easier for us to process everything without a decimal point. 2nd through 7th are alpha or numeric. And the 7th character does something we never had the ability to do before. Number 1, it can act as a placeholder. And a placeholder is important because in the future, we want to be able to expand this set of codes. ICD 9, when codes were thrown into that structure, there's no space in between some of the codes to add more granularity. With ICD 10, we add more granularity. This 7th digit tells us some interesting things about other code classes like obstetrics. In obstetrics now, we can use that 7th digit to say what trimester, what period of the pregnancy is this occurring during? Because an abdominal pain in one early part of pregnancy has a different connotation than abdominal pain in a late part of pregnancy. So that's one way. Musculoskeletal injuries are huge. Guess what the 7th digits tell us here? They tell us if this is the initial episode of care or a follow-up or subsequent episode of care or what's called a sequela. Now, again, I always go back to falling down and breaking my arm. I fell down, I broke my arm. I go to my doctor. That initial care is for the broken arm. Initial episode of care. That gets an A after at the end of the code. And that means the doctor treated me the initial episode of this broken arm. So I go to the emergency room for that. I get a procedure code and a diagnosis code. When I go to follow up at the orthopedic surgeon, he or she has to have some way to say that it's not the initial code, because if they said it was the initial, guess what? They're going to be billing that procedure code and they're going to get paid for something someone else already got paid for. That's a huge problem in Medicaid today. We can't tell by the diagnosis code if it was the initial or the subsequent, because all it says is broken arm. And then what about 10 years down the road when I go back because my arm is now gnarled up because of a sequela, an after effect, a late effect of that fracture? Well, if you just submitted the broken arm code, all you're going to say is broken arm. Dang, the insurance company says he broke his arm again. Does that doctor get the same amount of dollar value? No, shouldn't. Can you tell by looking at? No, you can't. So that's where that end point code and causes of injury comes into play. We'll look at these in just a little bit. So finally, some structure. This is a code for a displaced transverse across at an angle fracture of the humerus, the upper arm bone. So S42 says S means it was an accident. Broke my upper arm. The 3 says it's a humerus, this bone. The 2 says it's the shaft of the humerus, because the humerus has a head, a distal end, and a mid shaft. It says, oh, laterality, right versus left arm. And then finally, it says initial encounter. So we know that this injury was for me falling and breaking my arm and taking care of me right now. Interestingly enough, as time goes forward with these codes, this digit right here, the laterality, will make some sense. And let me tell you how. If I'm right-handed and I break my right arm, what does it say about my ability to work, to earn a living? It will affect it. Let's transfer this to the leg now. Let's say it's my right leg that's broken. If I'm primarily a right-footed person, and most of us have a definitive arm or leg that we use, if we have a fracture on our dominant side, the disability that we receive from that injury is much more complicated than our non-dominant side. It causes more problem. It has a higher risk for us in terms of complications moving future. If I go home with this broken right leg and that's my dominant leg, what am I more likely to do? I'm more likely to fall down the steps at my house because it's my dominant. I'm more likely, if it's my right arm, to not be able to drive, affecting my ability to work. So you see that the ability to show loud now is really important, has been important for years, but we couldn't show it for years. This now comes right down to the level of each individual injury. You can see this gives us a huge advantage. Some of the biggest pluses for ICD-10 is, well, we talked about it already, granularity. That's the biggest. We get much more detail than we ever had before. We can paint a bigger picture. I used to always say the documentation, when I would teach doctors about documentation is either a crayon in a color book or a beautiful oil and watercolor. It's how you paint it and what people see. More granularity, watercolor versus crayon, more information involved, conveys more risk. Laterality, body areas. It's not just right versus left now. It's spot within a bone. It is dominant versus non-dominant sides. It's areas within the belly. If you said somebody had belly pain, well, how many regions of the belly? Well, we normally think left upper, left lower, right lower, periumbilical, suprapubic. Now we have the ability to further define body areas. We talk about breast cancers and lumps and masses. The new ICD-10 code set allows the doctor to describe in the quadrant which quadrant of each breast that mass lies. Whereas before, physicians would use, and we wouldn't be able to tell. It would be left breast or right breast. So they're poking all around trying to figure out where it may be. With this code and this anatomic specificity or granularity, we know exactly where these types of injuries and occurrences are. Much more granular. The episode of care, we kind of talked about that earlier, is really important, especially for reimbursement purposes. Surgical complications. We never had a great way of discussing surgical complications before. You had an infection. Well, that infection was related to surgery, but what kind of bug was it? And was it indeed following surgery? Well, it didn't matter in the old code set. Now we can describe a surgical procedure with the complication, all wrapped into one single code. If somebody was on the table and they had a surgical procedure and they had a hemorrhage during that procedure, we didn't have a code to accurately describe that. Now we do for many, many surgical procedures. Now, back in the day, we used to group by categories of injury. We said it was musculoskeletal. This whole chapter was all about musculoskeletal injuries. Now we take that chapter and we say it's extremity. No, it's not extremity. It's what occurred in this particular area. If we're going to talk about bones, it's the entire bony structure of the body. So instead of grouping it by a broken bone or a cut or whatever, we say it's a cut to the arm, it's a cut to the head. It's much more specific by areas of the body. Combination codes now, and I've got two really opposite examples I'll show you in just a minute, but combination code shows the diagnosis, the etiology, which is where it came from, and manifestations. You hear about people that have heart disease. Well, they have high blood pressure and heart disease. And they had a heart attack, and they had high blood pressure and heart disease. We used to have to diagnose and use multiple codes to describe exactly where they were at. Now with combination codes, we can tell everything in one single code. California only currently accepts 2 diagnosis codes. 2. They should accept 25, but now they only accept 2. So if you had somebody that had multiple injuries, how are you going to pick which is the most specific diagnosis code that you're going to use to get paid? ICD-10 and HIPAA 5010 is going to require that they utilize all these new codes. Conditions that are new or were not fully described before are also included in ICD-10. Pretty cool. And additional information about ambulatory and managed care encounters. We know now we do, well, Catman folks, managed care. There is a different way that reimbursement occurs for managed care. We didn't have diagnosis codes that were able to reflect that. There are managed care exams that are required by managed care. We didn't have a way of documenting why. ICD-10 looks at things like ambulatory status, ambulatory surgery status, and managed care encounters for specific managed care guidelines. All of these come with ICD-10. This is just a look at all of the different chapters. I threw this in there because it's a nice reference, but it talks about, and again, look right up at the top, infectious and parasitic diseases, as in ICD-9, 87654, and all the way back. Infectious diseases, number 1. Neoplasms, cancers, tumors, number 2. Because in history, that's how most people die. You got something communicable or you got a cancer. And then we define it by the blood, the endocrine, mental disorders, and then we break it down into the nervous system, eyes, ears, and mastoid process. Eyes and ears used to be one chapter combined. And they finally said, well, with all this new stuff that we're doing for eyes, we really need to get a better definition of eyes. And all the eye codes before were just for one eye. It wasn't about, there wasn't any bilateral codes or laterality effects with the eyes. And you know that for the most part, all of us have one dominant and one non-dominant eye. Again, it's important to know. Circulatory, respiratory, digestive. We break it out for things like the genitourinary system. Pregnancy and childbirth have its own chapter because it's a big and important chapter. Someday we'll talk about why Medi-Cal finds that, or Medicaid in general. This is one of those things that Medicaid is mandated to cover. One of the very few things that Medicaid is mandated to cover by the federal government. And it goes all the way back to the beginning of the Medicaid program. Pregnancy, perinatal illnesses, congenital malformations, huge chapter, symptoms, signs, and abnormal findings. Because a lot of times when you go to the doctor, you say, "Doc, it hurts when I do this." Don't do that. I don't know what it is. I'll run some tests. It's a sign or a symptom. How often have you gone in and said, "I got this or I got that, and I don't know what it is." Doctor says, "Well, let me run some tests and I'll let you know." It happens all the time. How do we document those encounters? If we're going to give them a procedure code for coming to the office, we have to have something that brought them there. That's where signs and symptoms come in. Injuries and poisonings, external causes of morbidity, mortality, what makes us sick, what makes us die from the outside. Smoking is one of those things that we include in there, drug abuse, et cetera, et cetera. Factors that influence our contact with healthcare. Why do you go to the doctor? Well, most of the time, because most everybody in here is younger than me, you go for, I gotta go have a checkup, or I gotta go have I cut my finger on a tuna can, or I was building the kids' swing set. That's pretty straightforward and easily driven by a code. It's a routine medical examination. It's a required medical examination. But then you've got old codgers that have all kinds of illnesses and diseases, it's really easy to pull something up here. But young and healthy people, how do we describe why they go to the doctor? We have to have a reason because they go. Other factors that influence healthcare services. Okay, here's my first funny picture of the day. This is not Steve. This is little Joe. Little Joe fall off the bike. He was on the bike path, driving around the zoo, broke his arm. So the procedure code is 25500. And that procedure code says this is for a closed treatment of a broken forearm bone. Has a Medi-Cal value of 148.06. Break your arm, that's what the doctor makes for that particular initial surgical care. So diagnoses in ICD 9, 81320, it's a closed fracture of the shaft of the radius or ulna, one of these two bones, somewhere in the middle. That's all we know. That's what the code says. This E code says this was a pedal cycle injury. We call them bicycles. We don't call them pedal cycles. Guess what? It's a throwback to the 1700s. There were pedal cycles, you know, those really great big wheeled pedal cycles. Not bicycle, pedal cycle. In ICD-10, we find a lot more out about it. Number one, it's a green stick fracture because this is little Joe, and little Joe is a kid and his bones aren't fully formed yet. And a green stick fracture is a bone that has been stretched, bent, and partially broke, but not all the way through. That's what kids do all the time because their bones aren't fully calcified. Like me, I would be in traction. My son, when he was little, broke a bone, and it's a green stick. It heals a lot faster. This portrays that. It's of the right ulna, radius, ulna, the initial counter for a closed fracture. How much more accurate this is. In the future, how much more can we change how this is paid with a better diagnosis? Is a snap-through bone on a 56-year-old guy like me more complicated to treat than a partial green stick fracture on a little kid? That's 5. Big difference. Right now, we don't change that. In the future, with this code set, we can. That's one of the big advantages.
So for this accident, we were doing 2 codes. Now we come up with 4 codes.
Now we come up with 4.
Isn't that more kind of time consuming?
It is, and I'm going to show you the exact opposite in the next slide.
Right.
This tells us it was a pedal cyclist, driver or passenger, unspecified non-traffic initial encounter. This does help us because it tells the insurance company this was not a auto versus bicycle. So there's not a third-party liability issue there. That helps. The activity was bike riding. Yeah, we kind of already knew that, Matt. But this one, the bike path was a place of occurrence. Now, if you're an insurance company, who are you going to think about going after? The bike path, the county, the city. Was it an unsafe bike path? Did that child break his arm and fall because that bike path was unsafe? Potential third-party liability. And through a computer process of processing this claim, you can tag this chart as being a possible third-party liability payer. Kind of interesting. Look at it a little bit different. Tells us why and what and where. Much more specific manner, especially for accidents. This kind of detail makes a big difference. Third-party liability is big. Now, many more codes. We said, yeah, went from 14 to 70. Same injury. Before October 1st, an open fracture of the shaft of the femur, there were 16 ICD-9 codes. Just 16 to describe every mid-shaft, open shaft femur fracture. After the date of compliance, There are 1,530 femur fracture codes now to choose from. That describes it much more specifically. This says it's a displaced, see the piece of bone that lies out, comminuted, which means it pokes through the skin, fracture of the shaft of the right femur. It's an initial encounter, and the fracture type is a 3A, 3B, or 3C. And that's different than a 1A, 2A, 3A. So it tells us the type of fracture. These little fracture numbers here are driving orthopedic doctors crazy because they have to document the type of fracture it is now. Not just that it's broken and comminuted, but what classification of fracture. But again, this will allow us in the future to reimburse at a higher level.
And I think this will allow us cross-country or across the globe diagnosing and treating the patient.
Exactly, because this classification was Gustavo fracture classification originated in another country and came this way. We can convey that information now. So kind of interesting, but you can see the big jump in codes. This is a picture of my eye. No, not my eye. Mine's not quite that bad yet. This is an example of combination codes. Remember we talked earlier about combo codes? So at least 25% of all diabetics have eye conditions caused by the high levels of sugar and what it does to the retina, the vessels in the eye. So in the old days, ICD-9 right now, coding for a patient that's got this condition, which is diabetes. This patient has ophthalmic manifestations and type 2 diabetes uncontrolled. That's just the diabetes. That's just the underlying disease. He also has diabetic macular edema, which is just fancy word for swelling around the macula at the back of the eye where the vision focuses into. He also has severe non-proliferative diabetic retinopathy. See all these extra little blood vessels running everywhere? It looks like you just got a red pen and started drawing extra ones in. They make no rhyme, no reason. In diabetes, those vessels grow extra, and not only do they grow too much and they create their own blood supply, but they also burst and leak blood. And that causes a cloudiness of the vision. So this one person who goes to the ophthalmologist has all of these things going on for that eye exam. The coding rules say they've got to use all of these codes. And this last one, the B5867, says long-term current use of insulin. That's a risk factor with diabetics. The longer you're on insulin, the more risk you take. Now, in ICD-10, we have this combination code. This is type 2 diabetic, severe non-proliferative diabetic retinopathy, and macular edema. Rolls all three of these codes together in one. You can imagine that there's a whole lot of combinations in this diabetic spin the wheel.
So when they go to the doctor, somebody has to look this up, right?
Ah, good. That's where we come in.
70,000 items.
We look them up in a book. The majority of coders use a great big thick book. And lots of them use what are called cheat sheets. If you see an ophthalmologist, he or she has a cheat sheet of a few hundred codes that they use all the time. If you see an orthopedist, they don't need all these other codes. They only need the orthopedic codes. So they use a cheat sheet, or in EHRs and EMRs, they type in a diagnosis and down drops the list with ICD-10 codes to choose from. So it prompts them as they add text to a system and will show them more and more codes. But it is building a code. And we're only talking about diagnosis today because the rest is way more complicated. This is just all about diagnoses. So you can see, if we were in California submitting to Medi-Cal, we're going to have to choose two. And actually only one of them is going to get placed on the claim. The great thing here, we're only using 2 lines worth of code. We got to look up 2 codes. So what's next? Well, October 1st, 2015, all patient encounters have to submit ICD-10 codes as of October 1st, except workers' comp. CMS, however, recently has granted what's called safe harbor. It's a get out of jail free card. CMS says, well, because you've all been belly aching for the last 3 years and you're all belly aching again, here's what we're going to do. As long as your code is close to and in the right family, that 3-digit family, if it's somewhere in there, we're going to pay the claim. So for the next year, you get a get out of jail free card. It's very easy. My question is, what's going to happen 1 year down the road? When this whole year of 2015 is a year of junk data. That's my new Chinese New Year, the year of junk data. Because it's all going to be junk data. CMS is only going to say if it's in the right family, close enough for government work. Who collects the biggest amount of data? It's the government. So real change begins next year when we have to sit down and say, we're going to start changing the way we pay these things because you're going to get paid too much. Now we're going to stratify claims. We're going to say, we're going to pay you based on the diagnosis. So we're going to reduce the value of some of these or increase the value based on diagnosis. That's what this allows us to do. Everybody hear of value-based payments, value-based programs, value-based purchasing with Medicare? That's another part of what ICD-10 is all about, is when we hear value, what they really mean is quality. Quality care. When doctors report these diagnoses, if they report certain diagnoses and certain procedures that they do, they're considered to be high quality service. These are quality guidelines, and if you've got a patient with this diagnosis and you do this, they are good quality care. If you don't, you're in trouble. When the quality care started, if you reported these codes, you got a bonus. Now, if you don't report these codes, you get a penalty. So when you talk about 1% or 2% of all Medicare claims, and somewhere up to 5% cut back on claims, it's a huge deal, especially when you figure the margin of profit within a medical practice may only be 5%. And if 80% of your patients are Medicare and you start cutting 5% off of 80% of your practice, that's a significant amount of money. So that's what this is all about. What's next? We got a year of living dangerously, and then we get really busy. And that's it. So we kept it right at an hour, right? Does anybody have any questions?
Yes.
Yes.
So, excuse me. So I go to the doctor. So the doctor looks at me, and somebody in the doctor's office, they're going to look up the code.
Right.
They're going to enter it. It could be one or multiple, right?
Right.
Then they submit it. It goes downstream. What if I'm the coder, right? I don't know the right terminology for that person.
Yep. Coder.
The coder. What if I make a mistake? It's kind of
Yes.
So
Then you have trouble.
This happened to me.
It does happen all the time.
uh-huh.
But the problem being is when a claim is submitted by a provider, the responsibility for the accuracy of the claim goes back to the doctor. So if the coder makes a mistake, the doctor has to pay the price. Of course, the coder's going to lose their job, but the doctor has to pay for it. Now, depending on what kind of error you make, and CMS comes out with a new book every year that how they're going to look at and audit claims to look for errors and trends that groups and physicians do. Doctors know in advance what they're going to get looked at. They know every year. This year it was the orange book, and last year it was the blue book. But they know what's going to happen. And they know that CMS is going to focus its audits on a particular range of codes. One of the recent things is, remember we said about the broken arm and there's an initial care and follow-up care? Well, too many doctors were billing initial care for both visits. So they're getting full amounts. They're not getting percentages. So CMS says, this is the year of the follow-up visit. And they went after, specifically pulled these codes that we use, and they pulled from their incoming claims, and they just did a very simple rubric to match up the codes and started saying, okay, I want 10 of these claims from your office, doctor, with this diagnosis code. Set them all down side by side, audit all 10 of them, and see how many of them are accurate. That's how CMS does their auditing. They pull 10 claims, call it a representative sample, and then fine accordingly by how many claims you actually file. So if you didn't do well on 10, you're in deep yoga. You better hope that what you're coding for is accurate on every single claim. So number one, doctors at fault.
But that's on the public sector government, right?
That's everyone.
But if it is private sector,
the ones that go after private sector physicians are the patients.
yeah, but the patients don't know the codes.
Yeah.
Right.
So if the doctor says this is the code,
Right.
the patient has no way to
This
argue.
is exactly
Well,
what
it could
happened.
be
So I went for
denied.
it.
Sorry.
No.
What I was saying is could be denied by our insurance company because they kind of.
Oh, yes, they do all the time.
So that's how
No,
I got
deny
it.
insurance may, yeah, that's
You
the
have
thing.
insurance.
So I went for a preventative, like you said, young person, just check up, just say hello. And I was like, oh, insurance is free, just go and get like whatever. That's part of it. And I was like, oh, it's free, I'm not gonna lose anything. Then I get a $300 bill. And then I call my insurance company and they say, oh, the doctor's office coded it wrong. It's coded and they diagnostic visit instead of the
Instead of
preventive.
preventative healthcare.
And so then I said, well, okay. So each one, so for 1 year, I was in limbo because each were
Their
pointing
fault.
fingers
So it's
at
up
the
to the
other.
patients to actually go.
Yeah.
and
It
follow
is
the insurance.
caveat emptor. It is the buyer beware. And that's why there are a lot more kind of niche market advocacy of expert coders helping patients with claims. I look at every claim for everything that my family has gone through because I frequently will just pick apart an operative report and say, no, you didn't do that. No, you didn't do that. No, you didn't do that. So I make sure when I go into my doctor's office, I let every doctor that I know say, this is what I do for a living for 30 years.
Yeah,
And bring me along as I'm your advocate for correct coding. But what ends up strangely enough happening is most of the doctor's offices will have their office managers get my personal number and call me to help them with coding issues. Yeah, my doctor's office routinely calls me about coding issues to help them with coding. Because remember, these codes were written for doctors, but the doctors don't understand how the codes have to be applied.
They ended up blaming it on the doctor. They're like, oh, the doctor.
The doctor checked the wrong box.
Diagnostic. I was like, I made it very clear that it was preventative. So from now on, like whenever I'm sending anyone, I'm like, make sure you tell them clearly that this is a preventative visit or whatever it is, because it gets coded incorrectly, and then you end up saying that.
When the codes are input, are they just like manually entered by a doctor? It's like this is code.
Typically, they're a checkbox kind
Not
of
the
thing,
doctor.
or an EMR or EHR.
Okay.
And they will have a coder look over the doctor's work and adjust the codes accordingly.
So this thing is long-term, is not to help the doctors. This is,
It's all about reimbursement.
Yeah.
But
Insurance
Look at the right
companies.
some advantages are going to be better quality of medicine.
Yeah.
We're going to be able to
long-term, they look at
document
the
it.
history.
Yeah,
Yeah,
everything is going to be long-term with this.
yeah, I see that part.
So the bottom line is, you ever have problems with a medical bill and you want to know about a
We're
code?
coming back.
Just drop me an email. I'm just great.
All right, thank you, Matt.
Thanks, everybody, very much.
For your efforts.
Cool, thank you very much.
Is our system catching up?
And Melissa's gonna draw the name of the person who gets it.
Not yet.
Participation certificate.
Ours doesn't go with,
So you
that's
can
the,
give me a little sign.
that's
that
why
just say,
it's
if
famous
you're
and stuff.
all-
Yes,
Ours is
That's
famous.
right, I'm your
That's
advocate, I'm your coding advocate.
That's
It says
deeper.
Adam.
Fee for service.
I-
take care of
It's
that.
fee for service, then we
That's the
can,
only-
for us,
I mean,
it's
that's the only
always.
other
It's
thing
just,
we need.
anyone
Just add a
in this
little
room
sign
gets
that
your name
you're
down on
taking
the list, and you draw it, and you get a gift.
Yeah.
Hi, Madan, how are you?
Actually,
Hi, Stacy.
You can see it, that's all I have.
So Matt, what is the intermediate solution that you have, which converts 10 to 9?
We built a crosswalk,
Crosswalk.
and part of the problem is the way that the
Like a
code.
translator?
For now.
From
Yeah.
9 to 10?
Oh, it's actually,